We are basically going through the group of disorders which have the psychiatric origin and they have their physical manifestations on the particular person who is suffering from the somatization disorder over here. So in this particular section, we are going to consider the conversion disorders over here, which are also known as the dissociative disorders. Again, belonging to this condition which is known as the somatoform disorders. What basically happens over here, the person has gone through the severe trauma and the post-traumatic stress disorder is sometimes manifesting itself in the form of conversion disorders in these people over here. So in this very third section, we'll be focusing on the DSM-4 criteria of the categorization of the somatoform disorders as well as the conversion disorders. What are the different characteristics of these conversion disorders? The epidemiologies will be discussed over here. What are the occurrence rates of such somatoform disorders? That is again going to be discussed over here. The phenomenology of the somatoform disorder, that is also going to be discussed over here in this very third section. So this is basically giving you an overview on the conversion disorders. What is the different symptomatology or the clinical presentations that are frequently present in the different individuals suffering from such conversion or the dissociative illnesses. The causative factors are obviously different in different cases. Usually the person is doing a lot of research on the illnesses. He's having someone in his or her surrounding who is suffering from a severe illness. So again, he's going to suffer from that hypochondriacal condition in which he's going to have that unwanted or unnecessary fear of suffering from a serious illness. So that is going to be characterized as the hypochondriacal condition in that person. Over here, when we look at the DSM-4 or the 5 classification of the somatization disorders, it's basically the somatization disorder is the disorder of having the somatic symptom in that particular person. Then hypochondriacal disorders, we've already discussed that. It's basically an illness, anxiety disorder, and it's caused due to the unnecessary or the unusual fear of suffering from from a very serious illness or a serious ailment, for example, cancer or HIV. Somatoform pain disorders. Again, pain is something that we cannot investigate in a particular person. So it's quite difficult to investigate whether the person is suffering from some sort of a somatoform pain disorder or he's actually suffering from some sort of a pain. Pain disorders are SSDs with the predominant pain in such people. Then we have the conversion disorders, or they're also known as the functional neurological somatoform disorders. Again, the symptoms are going to be more of the neurological type in such people who are suffering from the conversion or the dissociative disorders. The history of trauma is going to be present in such people who are suffering from the dissociative or the conversion disorders. The body dysmorphic disorder is one of its kind. It's basically the obsessive compulsive disorder spectrum that is seen in such people. We've already discussed bulimia nervosa and anorexia nervosa. Usually the people who are suffering from bulimia or anorexia nervosa have this kind of a disorder, which is basically the body dysmorphic syndrome or the body dysmorphic disorder. Usually these people will think that they're overweight. In reality, they're not overweight, and in fact, they are skinny or underweight, but still they're going to restrict their diets to such a level that their daily routine life is going to be affected due to their behaviors. So that is the body dysmorphic disorder. Then we are going to have the psychological factors affecting the other medical conditions in such patients, the undifferentiated somatoform disorder. So sometimes one cannot really categorize the disorders into all of these categories. It cannot be a somatization, hypochondrial, pain disorder, conversion, body dysmorphic syndromes, and it's basically an undifferentiated somatoform disorders that is seen in a lot of individuals. Sometimes we have the somatoform disorders that are unspecified and that are usually not differentiated in any of these categories. So this is the DSM-4 or the DSM-5 classification for the somatoform disorders that is seen in these individuals. Then we have the conversion disorders, that is the loss of or alteration in the physical functioning suggesting a physical disorder. Usually they'll come up to the clinics with the paralysis or unconsciousness. So basically they're suffering from the conversion or the dissociative disorders. One should know how to differentiate or basically distinguish between a conversion or a dissociative functional disorder and the malingerers. So this is very important over here to clinically differentiate between these two kind of conditions. Most commonly, they are the pseudo-neurological, the DSM-4 criteria that is typically preceded by the conflicts or the stressors and not intentionally produced in these individuals over here. Now, when we move on to the epidemiology, that is basically the occurrence rates and the prevalence of such conversion disorders, again, very frequent disorder. Female preponderance is seen in such patients. The onset is usually between the teenagers and the young adults. That is the most prone age group that would usually present as suffering from such conversion disorders. Usually the people would be belonging to the lower socioeconomic group and they'll be more prone to the development of such conversion disorders. Now, when we move on to the phenomenology in these disorders, the traditional mutism, deafness, blindness, syncope, seizures. Syncope is basically the loss of consciousness. Then we have amnesia, that is the loss of memory. It can be of both the types, that is the anterograde, or it can be the retrograde amnesia that is observed in these individuals. Then the patients may be suffering from paralysis or even anesthesia, that is the loss of sensation. Even the loss of pain sensation, the loss of the sensation of touch is sometimes observed in these individuals. These subtle, sophisticated, more diagnostically challenging presentations are sometimes seen in these individuals. Then the plasticity of the symptoms. So if you have more exposure towards the clinical symptoms or towards the clinical pictures of all of these conditions, that is, even a seizure or a fit can be diagnosed by a person who is well experienced. So usually you would notice the plasticity of the symptoms in these patients. The symbolism versus the identification and then the imitation. All of these can only be observed by an individual who is well experienced in his field. Only then you can basically differentiate between a fictitious disorder and a genuine illness, whether he's suffering from that or not. In the comorbidity, basically, it can be comorbidly linked towards a neurological disorder. Then the psychiatric illnesses can be linked towards such sort of conversion disorders. It can be the psychosis, depression, personality disorders, for example, the obsessive compulsive disorders, or the people who are having basically the type A personalities. Then the other somatoform symptoms are also seen in such people. So over here in this section, we just summarize the condition of the conversion disorders and the other somatoform disorders, which can range from the pain disorders towards the neurological symptoms. Then we have the undifferentiated or the undiagnosed disorders are also sometimes put forward in this categorization. So one should know how to basically differentiate between a real somatoform disorder and the genuine illness. So that is the end of this section. Thank you for watching sqadia.com.